All right, let's just jump right into this explainer because the source material we're looking at today completely flipped how I view a standard lipid panel blood test. For decades, we've been fed a very simple story about heart health, right? Lower the bad cholesterol and raise the good cholesterol as high as you possibly can. But as you'll see, recent medical data is flipping that script entirely. Welcome to our deep dive into the great cholesterol paradigm shift. We are coming right out of the gate here, challenging a huge, decades-old medical myth. Is it possible that higher HDL levels aren't always better for your heart? Well, it turns out that simple, higher is better advice might actually be putting certain people at a dramatically higher risk for cardiovascular disease. But to really understand why your so-called good cholesterol might secretly be turning against you, we have to look closely at the actual mechanics of what's happening inside your bloodstream. Section 1. The biological baseline. Look, before we start labeling the numbers on your lab results as strictly the good guys or the bad guys, we need to remember that cholesterol isn't inherently evil. It's actually this vital, waxy, fat-like building block. As the CDC and clinical physiology texts point out, your liver naturally synthesizes all the blood cholesterol your body needs to survive. Without it, you wouldn't be able to produce essential hormones like cortisol, testosterone, and estrogen. You couldn't synthesize vitamin D from sunlight, and you wouldn't even be able to create the bile salts you need to digest fatty foods. You literally cannot live without it. Now, because cholesterol is lipophilic, which just means it's a fat that won't dissolve in the watery environment of your blood, it needs a ride. Enter the lipoprotein. You can think of these as little transport vehicles, essentially acting as cars driving the cholesterol passengers all throughout your vascular highway. When we watch this cellular traffic, we're mostly tracking two main vehicles. LDL, or low-density lipoprotein, is your delivery truck taking cholesterol to the cells. But when there's too much of it on the road, it leaves cholesterol trapped in your arterial walls, making it the plaque builder. On the flip side, HDL, or high-density lipoprotein, is the plaque sweeper. Its entire job is to drive through the bloodstream, pick up the excess LDL cholesterol, and bring it right back to the liver to be broken down and removed from the body. Moving on to Section 2. Decoding your lipid panel. So when you get your routine blood work done, the standard scorecard shows exactly where you generally want your numbers to land to keep your cardiovascular risk low, at least according to the Cleveland Clinic and the CDC. You want your total cholesterol below 200 milligrams per deciliter, your bad LDL should be under 100, your triglycerides, those are the fats used for energy, should be under 150, and your good HDL should be above 40 for men and above 50 for women. And for years, the guidance on that last number was simply the higher, the better. But keep in mind that total cholesterol number isn't just one standalone thing. It's really a mathematical combo platter of the bad LDL, the good HDL, and other circulating fats like triglycerides and VLDL. So if your total cholesterol comes back high, your doctor has to look at the exact breakdown to see why. Because if it's high purely because your good HDL is off the charts, that used to be celebrated. Not anymore, though. Which brings us to Section 3, the HDL paradox. This is honestly the most shocking revelation in recent cardiovascular science. Hitting this seemingly perfect number, 80 milligrams per deciliter for HDL, actually marks the exact threshold where your good cholesterol turns on you. The medical community used to literally give high fives for an HDL of 80. Today, it's a massive red flag. I mean, the data here from massive clinical studies highlighted by WebMD is just startling. It reveals this really dark side of having too much HDL. One large study found that people with HDL over 60 had a nearly 50% increased risk of a heart attack compared to those sitting in the normal 41 to 60 range. Let that sink in. Furthermore, older adults with HDL levels over 80 were found to have a 27% higher risk of dementia. And crazy enough, very high levels of HDL were actually linked to a higher risk of dying from all causes. The fascinating biological discovery here is that more is definitely not always better. Researchers have found that under conditions like systemic inflammation, certain genetic quirks, or even hormonal shifts like menopause, this excessive HDL starts acting exactly like the bad stuff. Instead of sweeping the plaque away, these bloated HDL particles actually lose their protective antioxidant effects. They can literally slow down the clearing of LDL from your arteries and actively contribute to vascular inflammation. Section 4. How atherosclerosis actually works. To truly grasp why this malfunctioning HDL is so incredibly dangerous, we need to trace the biological journey of arterial disease, which is called atherosclerosis. Step 1 is just minor endothelial damage, a tiny injury to your blood vessel's lining. Step 2, those excess LDL particles get trapped in that damaged wall. Step 3, Your immune system sends in macrophages to eat the trapped cholesterol, but they just gorge themselves and die, creating these toxic foam cells that form the core of a fibrous plaque. And finally, step 4, if that plaque becomes unstable, it ruptures. Now, atherosclerosis does slowly restrict blood flow over time, which can cause chest pain or leg pain, but it's this sudden, catastrophic rupture of that vulnerable plaque that triggers a massive blood clot. That clot is what causes acute, deadly heart attacks and strokes. That silent, decades-long buildup followed by a sudden rupture is exactly what we are desperately trying to prevent with clinical treatments. Section 5. Treatment and the elderly. Managing this silent buildup requires some incredibly nuanced clinical choices as we age, especially past 65. The treatment strategies completely shift depending on whether we're talking about primary or secondary prevention. According to clinical reviews from MD Edge, primary prevention is trying to stop a first heart attack from ever happening. Secondary prevention, however, is all about protecting a patient who has already survived a heart attack or stroke from having another one. While statins are absolutely our go-to, most effective weapon for lowering LDL, prescribing them to older patients means carefully weighing some pretty serious side effects. It's important to note that older adults are way more susceptible to severe muscle pain, known as myalgia, mostly because of naturally decreasing muscle mass. They also face higher risks of the drug building up in their system due to declining kidney function, along with potential hepatic or liver stress. Because of these real risks, the clinical guidelines heavily favor secondary prevention for the elderly. Basically, if you've already had a heart attack, the benefits of a statin almost always outweigh the risks, even well into your 80s. But primary prevention past age 75? Well, that requires some incredibly careful evaluation. Doctors really have to look at a patient's overall frailty, interacting medications, and total life expectancy before they just write a prescription for a daily statin to lower a number on a chart. So what about other drugs? Well, newer non-statin therapies, like ezetimibe and PCSK9 inhibitors, are amazing at lowering LDL. But the clinical review notes they just lack sufficient long-term data for routine primary use in the very elderly. Since older adults are historically underrepresented in clinical trials, these alternative, far more complex drugs are mostly reserved for severe, uncontrolled secondary prevention cases. There's this fantastic quote from the clinical review that just perfectly nails this modern approach to heart health. It states, "Chronological age does not necessarily correspond to vascular age. It basically means the number of candles on your birthday cake doesn't actually predict the health of your arteries. You could have a 75-year-old with the clean, flexible arteries of a 50-year-old, or completely vice versa." So what you should really take away from all of this is how absolutely crucial it is to talk to your doctor about your individual vascular risk, rather than just blindly trusting a standardized chart. You've got to discuss your specific risks, the potential danger if you have highly elevated good HDL, and the very real concerns of polypharmacy, taking too many medications at once. That's how you build a tailored, truly personalized plan. Which leaves us with one pretty massive question. What is your true vascular age actually telling you about the future of your heart? Now that we know our good cholesterol can sometimes go bad, and that treatments absolutely must be personalized to our stage of life, I really hope this explainer has empowered you to ask the right questions at your next checkup. Stay curious, stay informed, and we'll catch you in the next explainer.